time. Apologies for 2 weeks ago. We kind of forgot that part. So just a reminder, these sessions are recorded, but we still really love your video. And of course, free seeing me as always. So attendance, rename yourself like y'all have done. Let us know if there's more than one person in the room. We do, again, love videos on because then you look like people and not names. I don't care if you're eating or, just don't be doing anything inappropriate is, good. We'll get a form out very, very shortly on case presentations. The ECHO model is case-based learning. So, presenting cases, talking through it with the whole ECHO world doesn't have to necessarily be pertinent to that day. It can just be any topic, any patient that you maybe want little extra help with. If you don't want to use the form, which y'all don't have anyway at this point, just any kind of information you want to send us, even if it's just a quick email and we can just work through it. And just obviously make sure there's no patient identifiers. Upcoming sessions on these Tuesdays in 2 weeks, Susan Bolio is coming to talk about ACE scores and trauma. So that one will be super exciting. A couple weeks after that, mental health and addiction. So the overlap of those co-occurring disorders, because we all know it's major. And then obviously the break for the holidays, and then coming back in January with the overlap of addiction and chronic pain, because again, just like the mental health, there's so much overlap there. And how do you handle those kind of situations? A Wednesday echo session. So this Eric Garland is quite the researcher, and he actually is coming from, he just did this study from the NIH on this mindfulness oriented recovery enhancement program, one of those fancy long words that stands for more, on opioid use disorder and the great luck he has had with treating that. And then coming back in December, one session will be on macro induction. So do you just, with fentanyl especially, pile on the dosing, or should you do micro inductions and do the baby inductions? And then because, COVID didn't end in April, like we ended the COVID echo, COVID didn't get the memo that COVID was supposed to be done when we ended. And obviously Minnesota in the last 7 days has had the highest rates of increases in the country. And so, the MAFP called us on Friday and said, I'm like, yeah, of course we'll bring this back. Kurt and I were both on board. So we're starting it on Thursday, and we are going to have the MDH situation update. Chris Erzman, who's the one y'all see on TV all the time, she's coming. So people coming and just giving a situation update, taking a break. Probably the first Thursday in December will be Tim Shacker again, coming back from the U as well. So we don't really know how long we'll be doing the COVID sessions, but kind of like before, we're going to kind of wing it and see what the interest is, because of course there's a lot of things to talk about that have changed since April.
Although it seems like there's a lot of interest because already 100 people have signed up. So it should be fun.
All right. A weekly Addiction Connection podcast. We just released one on opioids and the bad things that opioids cause. Actually, we have an email now. So if there's questions or things you want us to podcast on, by all means, email us at the Addiction Connection podcast. Okay, so now we'll get to the legit actual talk we're supposed to be doing today. So on urine drug screens, these are much more complex than any of us ever thought. So I don't forget to say it. We do have a laminated, well, you can make it laminated. We can email it to you, urine drug screen kind of algorithm thing that is super awesome to have at your desk. I had it at my desk because even doing this, there's always things that come up. What should the metabolites be? There's no way to remember everything. And then all the weird things too. So, Kurt, did you want to start with the whys?
Sure. Now I'm in Colorado, so if anybody has any troubles hearing me, please chat and I'll just let Dr. Bell take over. So one of the big issues is really, why do we screen, and there's lots of different reasons that we screen people, urine drug screening or blood. And we want, number one, we like to ensure that the patient is actually taking their medication. And that might not seem like a big thing, but think about patients who have other people set up their medications. Often we've had run into situations where caregivers are taking their medication, the patient isn't actually getting their med. We like to confirm that the patient's not taking other illicit substances. And again, much of that is about conversations with patients. It's not about stopping patients or getting rid of patients. It's about having conversations. And again, the last one we already kind of touched on about setting up pills. We like to make sure that they're actually getting their meds. So really important.
Oh,
Next slide.
Kurt, just
Yep.
shut your video off. Your audio is good, but your video's not. So.
Okay. All right. All right. How's that?
Good.
So one of the big questions you always have to ask yourself is checking that UDAS, is that going to change what I do? And in some cases, you know, you're going to find that it doesn't and that it's not useful, especially if a patient comes in and tells you what they've been taking and they're coming in and asking for help. Often we like to confirm it, but there are times when I have not. When we see a patient, one of the things we always do right at the start is ask when they took their last medication. You know, that's very helpful. So you know whether the chance that what's the chance that it's actually going to be in there. Now, we don't let patients bring a lot of stuff into the bathroom. That can often go poorly. And we actually have a bathroom that has colored water. We've always done that because we've had many patients dip in there and take a little bit of water. And it's nice to have a room where water can be turned off so that they cannot be taking it out of the faucet as well. But I think one of the important things too is you got to make sure that they have an up-to-date care plan, because the care plan is really very much spells out that these are the things that are expectations of a patient who's on chronic pain medications. These are the expectations we have, and one of those is getting a urine drug screen. So really be really careful. We like to make sure that we're getting a reasonably good sample that we can count on. So next slide.
I do want to say one thing about that, especially the care plan part, is whoever fills the care plans out with the patients, you know, and we always have our nurse care coordinator really go through the whole care plan with them. They, you know, they have that connection, then that's who will be calling them in potentially for random urines, but explaining why we're getting the urines, because people will think you're trying to catch them or people will think you're signaling them out. It's important to explain that this is for your own safety. This is so, you know, you kind of bring up the whole thing if somebody's taking your pills. And if we have time at the end of the talk, Kurt, I think you should explain that situation we had with that one patient case. But you know, we having a convent right next door to our hospital in Little Falls, like we had nuns in our clinic all the time, and you know, they have care plans and they leave urines. And if you have that discussion up front, people will accept it. And you know, and you can't just signal out people, you have to treat everybody the same. And so just, it's really important who goes through that care plan talks about that part.
All right, so when to screen? Obviously, anytime a patient is newly started on opioids or any controlled substance, really, you know, the sleeping pills, the Ativans, any of those things, unless they're a short-term thing. You know, if you get somebody that had a patient death in the family and they need a week worth of benzodiazepine, I'm not screening those people. But when there's a suspicion of misuse, right? If there's some information that you've gotten where you're concerned that they're using other substances, that might be a great time to screen. And especially in patients who are high risk. There's many groups of patients that are higher risk with particular other diagnoses that may require close scrutinization. Now, when we do buprenorphine follow-ups, any of the Suboxone patients, clearly at every visit, for the most part, we're doing that unless they're a televisit. But we also, if we have concerns about diversion, often we'll get information from the police or somebody else that this patient is selling their medications. We'll often be screening patients for that. Often there's those little things, and we've talked about these things before, that will give us an idea as to whether or not a patient might be higher risk for misuse of their pills, and early refills would be one of those things that would often trigger us to be checking a little bit more closely. Now, witnessed urines. Now, obviously, these are much more accurate. I think that as time has gone on, we've probably done less witnessed urines than we did in the past. I think often when we're taking care of opioid patients in the past, those are patients that we would occasionally watch to make sure that we're getting an accurate test. We have many, many stories of patients who were doing very interesting things to sneak by. And sometime when we have more time, we'll talk about those. So it can be really helpful. And they can be random. Often we won't do it right away, but we will do it on other visits. And we tell patients that it'll be hit and miss. But again, it's a necessary part probably of any program, in our opinion, that where you're doing chronic pain medications or buprenorphine. There's, of course, a market for buprenorphine as well. It's important to have like-gendered staff. I think that always works better. And if we don't have staff, well, often we just have patient get in a gown. We just make sure that they didn't have anything strapped to their leg or anything, that was obviously something they were going to use to mislead us. Next slide. Do you want to go for that?
Sure. So how do you interpret this? And this is one of those soapbox things that we really have, and we talk about all the time with correct language, is a patient doesn't fail or pass a urine. Is the urine as expected or is it not as expected? It's not a positive urine or a negative urine. Is what you're seeing in the urine expected? If they're on oxycodone and they have it in their urine, awesome, it's expected. If they also have methamphetamines in their urine, it's not expected. And so that's kind of how you break it down. And we're going to kind of go through some of these things a little bit, but when they're not expected or the urine isn't expected, that could just be because, they're on oxycodone. You confirm that they took it this morning. That's why it's really important to ask a patient when they took it last, because, if they haven't taken it in 2 days and it's more of a 3 times a week med, it's not going to be there. So it's really important to ask them when they took it. But an unexpected urine could be that it's just not there. They have the wrong prescription. So they have oxycodone in the urine instead of hydrocodone. Well, that's not expected. Do they have something illicit, like methamphetamines? Did they do something to their urine to kind of hide things? We have a whole podcast on things. Drano is if you're going to fake a urine and use weird things, use Drano if you had to do one thing, but there's a whole podcast on that. Is it even urine? Sometimes you see a male that comes back with a pregnancy test positive because, they wasn't their urine. Do they have the wrong combination of drug? And we'll get to that. And then abnormal temperature. What's important, especially when we're talking about that combination of a drug or is this urine sample really a urine sample, is if the lab automatically gets a specific gravity every time, and all of a sudden their specific gravity just totally changes from their norm. Sometimes that might indicate there's something fishy going on. Is the pH just totally off? Or the dilutional thing, like I said. So if a person has used and they don't want to tell you that ahead of time, they'll drink a ton of water, and then the substance won't be there because they've overly diluted, but the specific gravity will kind of show that if they don't have the metabolites. So sometimes, and we'll get to the metabolites, but for instance, a buprenorphine patient, they're giving you a sample, they should have buprenorphine and norbuprenorphine in their urine, because that shows that the body has started to break down the drug. If they only have buprenorphine, they could have easily just cut a chunk of their film or their tab and thrown it in the urine specimen cup. And so you can tell if they've shaved off chunks of meds and thrown it in the urine so it's there like it's supposed to, if it's not been previously metabolized by actually taking it. And then obviously cooler urine. These are little things. I think the bottom line, and you'll see it in a minute, so I'll just kind of wait in a second. So how to interpret. So these are, there's a picture that was supposed to be on this page. It's on a different page. So this actually are 2 urine tests on the same patient on the same day, because the patient had something strapped to their leg. So they only had buprenorphine in the sample that they dumped in the cup. But then when it was kind of confirmed that this was not quite right, this is actually what was in the urine. So marijuana, methamphetamines, amphetamines, opiates. So this is why it's important to a point. So this was what was strapped to that patient's leg. In the next few slides, you'll understand why I kind of hesitate on some of these things. But do you need to order a confirmatory test? The screening test is only a screening test. You can't convict someone of using meth because they have amphetamine in their urine without getting a confirmatory test, because there's a lot of false positives, and we'll get to that. Even a negative test, we've gotten negative tests sometimes, and you get a confirmatory and it's just that much more sensitive of a test. It then picks up that they were actually taking their medication. And so Do you need to do it every time? Again, not necessarily, kind of like we learned in med school, like from Dr. Baker there. Like if it's the test you're doing is not going to change what you're doing, is it worth the cost? Benzodiazepines, and we'll see coming up, it is important to do confirmation tests if you're concerned. Again, what I just said. You know, if a Suboxone patient comes in and you say, well, have you used anything? Well, yeah, I used some meth. Okay, maybe you don't need to get a confirmatory test on that meth. They told you they used it. So you don't always have to get confirmatory testing. It's just important to ask the patient. And sometimes I won't get it at all. If you ask the patient and they're telling you at all, you know, doesn't matter. Does it really matter? Now, sometimes you have to, but yeah, it's important to remember that confirmatory testing especially is expensive. You know, urine drug screens add some cost, but the confirmatory testing is very expensive. Talked about metabolites to see if the body's actually like processed the medication. We changed this from a previous, opioid breakdown because it's prettier, it's color coded. And so this is one of the things that if you want that handout, we can get it to you, but it's really important to know what things are broken down to. So, you know, if we're talking about the oxycodone again, for example, and they only have oxycodone, but they don't have, especially noroxycodone, they shaved that pill. They didn't take it and it go through into their urine. It's important to realize codeine. So someone's on Tylenol number 3 or codeine cough syrup, which tangent nobody should ever be on. They should, you know, it breaks down to morphine. That doesn't mean they're taking heroin. It means codeine, a byproduct of codeine is morphine. So it is important to know how these things all break down so you really understand what they're taking. You'd hate to accuse somebody of taking Dilaudid because they have hydromorphone in their urine when really they were just taking your codeine or your morphine or their hydrocodone like they're supposed to. This is one of the most important things to remember. Not every one of these breakdown products on benzos, but these two, clonazepam and alprazolam, so Klonopin and Xanax, they will not test positive on a urine drug screen benzodiazepine, even if they're taking them like they're supposed to. The urine drug screen tests for oxazepam. And you can see all the other benzos and every one of them except these two, and then maybe some weird ones, all break down to oxazepam. These two do not, so they will be negative. So there is a reason patients like Klonopin and Xanax. There is a reason why these have higher street value because they won't show up in their urine. If it's a higher suspicion person and you feel like they need to be on a benzo, it might be worth putting them on something like diazepam or something else that you can easily screen for without the always added cost of adding the confirmatory. So big take home, these two drugs. I'll do this one, Kurt, and then you can take over. So, well, this one and the next one. So detection time, people always ask, well, how long should the heroin show up in their urine? How long is marijuana going to be there? How long is XYZ? So these are the approximate detection times, you know, and you can see things like marijuana, how often they use it. A person who's using all the time, you can expect a good month. Person who's using it once in a while, a week. But it's the methamphetamines, the amphetamines are big ones, benzos to some point, the different opioids, important. So roughly everything's like 2 days if you're going to kind of err on the side of that. But definitely things to keep in mind. You don't want to say, oh, you're not taking your med, and the patient says, well, I haven't taken it in 3 days. Probably why it's not there. You always kind of want to give the patient the benefit of the doubt. You want to continue to build that relationship. Then we added a fentanyl because when we made these slides first, fentanyl wasn't a thing. So fentanyl is again right around the 2-day thing after their last use. Hair test, blood test, Kurt will start talking about those in a minute, how long they stay around. Now, if it's somebody who's using fentanyl on a daily, it's potentially going to show up a little bit longer, but it is important to realize the fentanyl, it kind of still fits into that same window, but it's not going to test anything else positive. So Fentanyl will not make an opioid positive. Fentanyl will not make an oxy or any of that positive. The only thing that'll show fentanyl is a fentanyl test, which most current available point of care tests don't have fentanyl on them.
So one of the big questions, of course, is how do we approach a patient who has unexpected urine, right? And again, there's lots of different ways that this happens, but number one, the drug that's supposed to be in their urine is not there. And I think that, prior to the test, we should have already asked them, is this, did you take your medication today? Did you take it yesterday? Making sure that it's going to be in there. It's always that conversation. So why isn't this medication in your urine? And you can often get pretty interesting answers. Be aware that there are times where our tests are not perfect. And we actually had a case in our clinic where somebody's amphetamine, they were taking something for ADHD, their medicine would not show up on their urine. And in fact, they had the patient take the pill in the clinic, rechecked him hours later, still wasn't there, right? So our tests are not perfect. So it's important that we understand that. Next slide. Now, what about the unexpected things where there's an illicit substance? I mean, this is a question you asked. Did you happen to use something? Did you take a drink out of something that may have been contaminated? And really, one of the things we have to always understand is they'll be on other medications, and we always have to be very careful that when we talk to patients, that we understand it could be a falsely positive test. And there are many ways for that to happen, and we'll talk about that. One of the things that the patient obviously admits that they are having an issue, we need to evaluate that patient for a substance use disorder, and we need to get that patient the help that they need. I think in our world, if we get something unexpected in the urine, our job is not to get rid of the patient and cut them from our clinic. Our job is to get them help. Next slide. How about the adulterated urine? A part of this is that there's clearly sometimes intent to fool you. And that's always a whole different issue. We will get things back from the lab. And I think my most famous one is the urine that I got a call from the lab, and they said it smelled like Red Hots. And it clearly did smell like Red Hots and had the color of Red Hots. And the question would be, why are you putting that in there? What are we trying to cover up, and why? Because we can have a conversation, and if there's an issue, we really need to address it. We may have to involve the social worker. Again, we may have to have that patient evaluated for a substance use disorder. But you can go online and you can buy a dozen different things to make your urine look differently than it should. So again, that's on our podcast. Next slide. How about refusing to give urine? That's always a tough one. Obviously, if the patient says, I'm not giving you urine, it's pretty often it's because there's going to be something in there that they don't want you to see. The question is, what do we do if we have them on opioids? Do we refill their medication if they refuse to give a urine? And that's really a case-by-case basis. It's really understanding, this patient and what their situation is and having a conversation. But again, do they need to be evaluated for SUD? Do they have a concurrent substance use disorder? Next slide.
I just think it's really important to make sure, again, we don't just cut patients off. That's a big deal. You can't do that in the state. You really have to have those conversations, taper them, not just cutting people off.
So how about combinations of drugs? You could talk to the patient a little bit about this. You can retest the patient and just kind of see what the deal is. And again, it's again evaluating those patients. Again, not cutting those patients off. Understanding that if there's an issue, our job in that clinic is to really get them help. So, indications and settings for urine drug testing. Again, we talked a little bit about this outpatient. Again, when we're doing primary care, we're doing pain management, and they're on long-term opioids, or if they're on buprenorphine or methadone or any of those types of things. Clearly, that's where urine drug testing is going to take place. Now, one of the things that we push for a lot is our hospital to do urine drug screens, because we have so many patients who go to the ER with a major problem and they do not get a urine, and so we never really know what happened. And so really, that's something that we really want people to make sure that our urines are getting taken in the ER, so that we know in follow-up what exactly was there. And so lots of different ways or places they can show up, whether it's at a psychiatric admission or an overdose, or potentially a patient that's coming in with a seizure or other things. That urine drug screen is really critical.
I'd say one thing with the hospital or in the emergency department, it's important to also realize the timing that the urine drug screen was done, especially if they came in and they got benzos or pain meds already right away. That's definitely going to be in their urine. So you got to be really careful. Just like, when did you take your last med? When was the timing of that urine drug screen done in relation to any treatments they may have gotten in the ER in the hospital?
Yep. And again, clinical versus non-clinical. Obviously, some of the treatment centers will be getting urines. Occupationally, we see a lot of urines come back, and then we have to interpret or recheck these things because they tested positive for something. Child protection often is using these in follow-up of moms and dads, and of course, drug court. And often we're doing the urines for the drug court, but often they're doing their own as well. And those are all witnessed, which I think is one good part of that. But of course, public health occasionally beginning urine drug testing. And sadly, sometimes we're getting that post-mortem.
Yeah, and one thing to think about with the drug court and with probation, and like Kurt mentioned, if they're on the color wheel, well, they get random, they have to call in. So what a color wheel is every day the person has to call into some recording, and they all have an assigned color. And if they call in and say red, the voice thing says red, and you're a red colored patient, you have to go in and have a drug screen that day. And so it's random, and different colors get called more often. But if the patient is having those, to then also do them in the clinic can sometimes be extra costly to the patient. We've had times where it's more costly for the patient to get it done through county. And so we will get them for county, and then we just have to make sure they're all witnessed. So, you really want to always put the patient first, of course, and taking all of that into consideration. I mean, I've had patients that are like, I just left probation. They just left them a urine, and it's patients who confirm that, yeah, this is true. I don't repeat that.
So lots of different methods. Did you want to go, Heather, or do you want me to keep
going? Because these next few ones are the busy
ones.
So we just put these in here. So if y'all want the slides, you can really deep dive into the different types. Immunoassays are the ones that are typically in the clinic. The fast ones, they are not confirmatory. Again, we've said that 100 times. Chromatography looks for other things. It still takes a little bit longer. It can be the next step when you're doing a confirmatory test, but mass spec is really the big thing. These do not come back quickly. Depending on the substance, it can take a long time. This we often do if you can't figure out what's going on. A person comes into the ER and they're having a psychotic break, and you're sure there's some type of a substance on board, and you just can't figure it out. This is where you get to these fancy things. So the immunoassays, they have rapid turnaround times. They're qualitative. You can kind of see all these. The problem with the immunoassays, the rapids, is the false positives, the false negatives. And so just being aware, this is more just those screening things. Really can't stress this enough. What are the contributing factors when it comes to urine drug screens? Is it patient time? Is it what other things play in? What are their other medications? What tests do you have available even in your facility? Not every facility has point of care testing. Not every facility has fentanyl test strips. So it's being aware of the limitations and then just being okay with that. You might not have the ability to get a urine drug screen back when a patient's in the clinic. That's okay. Again, if you can build that relationship with patients, they will often tell you what they have used, even if it's not going to show up. And so you get the urine drug screen every once in a while because you legally have to, but it's okay if it's not back immediately. It's nice, but it's not necessary. And then the tiered approach. Is it necessary to get the confirmation? Is it necessary to do those things? Look at the whole picture. And then for the millionth time, never accuse a patient. Ask them ahead of time. If you see something that's unexpected, ask them about it. Did they take a different medication? Did they take Sudafed because they had a cold and now they have amphetamines in their urine? It's always important to ask and never accuse. You want that patient relationship. You want the patient to be comfortable with you. If they do have concerns or they are starting to look like they have a substance use disorder, you want to be that safe place. So why do we use urine? And we'll get to why we've been even tricked with this. Urines are easy. It's non-invasive. I mean, we have had patients that would rather you cath them. I don't know why, but for the most part, people can pee in a cup. So it's easy. The drugs are very concentrated. You know, your kidneys break down meds and then they're like stored in your bladder for a bit. And so it's sitting there and they've already been, you know, metabolized and they're just there. So it has a longer window of detection. And then you can see, of course, those metabolites, like I mentioned, because you're going to be able to pick those up. Pitfalls, you know, you can dilute things with drinking a ton of water. You can add ammonia, bleach, Drano to the urine. So it's easier to, you know, fool the test, you know, whether it's the Whizzinator and all the fancy things that people can do. And so there are limitations. And so they're just to be aware of those things. If something doesn't make sense, you know, just to pursue that if it's necessary. So when would you get something? Here's the common ones: blood, saliva, urine, sweat, and hair testing. I love this chart because it really kind of lays it out. What's invasive, what's not invasive. Obviously, drawing blood is more invasive. What are you looking at? The metabolites or the parent drug or both. And so it is important to remember what you're looking at. You know, you won't see the parent drug in urine, especially for something like heroin, but you might not see it either in
saliva. Even though saliva is a parent drug swab. So it's just kind of to be aware. The window of detection, I think, is the biggest thing we look at. Patients know that things get out of their blood faster. And so at the beginning, patients say, can I just give you a blood? Can you just draw blood because I just peed when I got here? Well, they know that their amphetamines or their heroin or whatever is going to be out of their blood way faster than it's going to be out of their urine. And so it is important to remember that. Sweat tests, the disadvantage to that is it's annoying to patients. It can be contaminated. It's just a very complicated one. The only people who really do sweat tests are, you know, like probation and county people do those. And hair tests, you're not actually testing the hair, you're testing the hair follicle. So it says non-invasive, but they have to cut the hair really closely to the scalp to get that. And there are differences based on obviously length of hair, texture of hair, color of hair, dyeing of hair. There's a lot of variability in that. I do want to mention the buprenorphine because we got this question a lot at the beginning. We asked this question a lot at the beginning is, why isn't it in the urine? So some tests, you know, go down to the lower cutoff. Some tests it's the higher cutoff. So being aware of that. Again, if there's a question or it seems like a weird result, ask questions. Don't just assume. Buprenorphine has all those metabolites you can see on the chart. The biggest one we look at is that norbuprenorphine because you can see it has the highest rate of detection. But there is no good ratio that will tell you. So you'll have patients who will be taking their Suboxone and then they might stop it for a few days so they can use, and then they start using it again because they go into withdrawal. So they'll start their Suboxone back up. And so sometimes you're questioning, like, is this patient really taking it or not? Getting the ratio is not helpful. You cannot tell when the patient took their buprenorphine last by getting a ratio because of the way all of us break down meds. The only useful ratio is if it's right around a 1-to-1 ratio. If it's a 1-to-1 ratio, buprenorphine to norbuprenorphine, it's a pretty good indicator they took their med within the last hour. So it's a person who's not using their buprenorphine. So a person who maybe isn't using anything, but they're a meth patient who got on buprenorphine so they could sell it, so they could buy more meth. But they know that they have to take it before they come into their appointment, so it shows up. So the 1-to-1 ratio is kind of key, but anything else isn't helpful. So summary, and then we'll let Kurt talk again. So, why are you doing it? Ask the questions.
what are you trying to get from doing the test? Where is it being tested? What type of test are you using? How are you going to do this, whether it's witnessed? Being aware that, you know, the toilet color water, it was on the slide, Kurt didn't mention it, is we've had patients take the back lid off toilets and scoop out the tank water because that water is in blue. But we one time did the drop-ins, you know, the toilet cleaner drop-in, the blue tab. So you put that into the tank. So the tank water and the toilet water is colored, not just spray the water in the toilet. You can get locked lids. So there's things you wouldn't think of. How often should you test? Who's testing? What kind of tests you have? So these are just kind of all the important factors to at least kind of have considered. Kurt?
Yes, and so do you need point of care testing? Some of the other issues. Number one, should you get levels? And Heather's already talked a little bit about buprenorphine and norbuprenorphine. Really, the levels, again, they have very specific times that I would be checking that. THC, for the most part, is probably not all that useful. I think that everybody, again, metabolizes a lot of these things differently, and benzodiazepines would be a perfect example of that. That although it can be very high, again, it's not overly useful. Opioids, there are very specific times where the levels can be helpful. One of those would be poppy seeds, and that's an upcoming talk on our regular echo, and I believe in January. There are times that the levels may mean something. And again, confirmatories are often used to make sure people, if it's negative, sometimes we will test it and see if there is actually some level of opioid and they were taking it, but maybe had not taken it the previous day. Amphetamines and methamphetamines, levels sometimes will mean something. Probably the one instance that I think about is in patients who take amphetamines for ADD or ADHD. One thing that people don't understand is that methamphetamine is actually a contaminant of Adderall and things like that. And so occasionally they will get a positive methamphetamine, but when you check the actual level, it will be very, very low, and their amphetamine will be very, very high. Remember, the direct metabolite of methamphetamine is amphetamine, and generally, if they are using daily, their methamphetamine is going to be the one that's going to be much higher. Next slide.
We will have an entire talk coming up on this echo on amphetamines with opioids, so there'll be many more details on that.
We're going to talk just briefly about things that don't show up in the urine that we always have to think about as well. Just remember that Gabapentin, which is a medication that is misused frequently, probably a third of people who get prescriptions for Gabapentin are misusing it. So understand that there are ways of testing for that, but that's one that does not show up in regular testing. Understand as well that this is used a great deal for people who are in withdrawal. They use it for alcohol withdrawal. They will use it for methamphetamine withdrawal. And also it is used concurrently with methamphetamine to increase their high and to make it last longer. So just remember that Gabapentin is also something in patients that may be important. Amphetamines, and again, we're going to hit on some of these things that are really important to understand for checking urines. Amphetamines are the most commonly false positive test that you're going to see. There are many things that make it positive. The one that most patients will shoot out there right away is Wellbutrin. That can cause a positive amphetamine, but there are many others, including some of the SSRIs.
What I want to say about that just today, and it's because we just got a couple questions about that, you know, is all the ADHD drugs will flag positive amphetamines except Ritalin. Methylphenidate does not break down. It's not an amphetamine. And not so Strattera, I should say, but so it is important. So if it's a person that has a history of methamphetamine use disorder that really does need to be on something, I always go to Strattera first, knowing it's never going to work. But Ritalin, it's hard because you can't, I mean, you can test for it with fancy tests, but it's a good way to tell, you know, if they're on Ritalin and their amphetamines and their meth are negative, you can be reassured that they're not taking those too. So versus you put them on Adderall and then you're always questioning, is it really the amphetamine, the Adderall, or is it meth? And then the thing that Kurt mentioned with the Wellbutrin is being aware if a person has a methamphetamine use disorder and they're in recovery, if they're struggling in recovery, to not put them on medications that can be a false positive, because then again, you're always wondering, and then you're wasting a lot of money getting confirmatories all the time.
This is one, of course, that many of you know about, and Kratom. It was funny because I just was talking to somebody, in Joe Rogan, who's a big podcast guy, and he is very much into Kratom, thinks it's a great drug for people to take for their pain. But Kratom is an opioid, and it's been kind of marketed as this herbal way to help your pain. But we clearly have seen people in withdrawal from this. People develop tolerance very quickly, and we use buprenorphine to treat these patients as well. It does not show up on any of our screening tests. And in fact, you have to order a metragenine test, which takes a long time to get back if you want to do that as a screening test. So understand this is commonly used. Next slide. Tianeptine is also one that you should know about. It does not show up on any urine drug screens. It's difficult to get testing for. This is actually an antidepressant in Europe that is falling out of favor. Originally, they thought that it was an SSRI, kind of, but when they did a lot of research on it, they found out that it worked exactly the opposite way that an SSRI was. And it was later found that it's actually a mu receptor agonist. It acts like an opioid. This was something that we saw in northern Minnesota. There were lots of cases of this. If you have patients telling you that they're taking Tianeptine for their anxiety or depression, boy, that's a conversation that you want to make sure you have with them, that this is a dangerous medication.
And newborns will show up having neonatal opioid withdrawal syndrome with moms on Tianeptine. So that was the first way people started to realize it was a bigger issue, is they're not taking any other opioid, but their baby is clearly in opioid withdrawal.
Yeah, and this can be ordered on the web. So, other questions or comments people can, of course, send to us. I think we still have a few minutes, don't we, Heather? I could tell a case story.
Go for it.
So one of the reasons, and this is a case, I'm going to just discuss a case with quickly that kind of helps us realize how important it is to do urine drug screening, even in patients that we're not concerned about misuse. We had a very interesting case a couple of years back. We had a situation where the patient was an elderly male. He was seeing one of our physicians. They were getting frequent calls from somebody in regards to him that he was having a lot worse pain. And in fact, the pain was bad enough that the person who called and talked with the doctor said that she was wondering if maybe he shouldn't be switched from hydrocodone to Percocet, oxycodone. And the doctor very astutely just thought something seemed a little funny. And he had the patient come in, and the patient was in his 80s. And he did a urine drug screen on the patient. And in fact, the patient's hydrocodone was not in his urine. He then made a phone call to the family that they had released to talk to. And what he found out was that the family was not really involved in this patient's care, that a family friend had volunteered to help set up his medications because she was a nurse. And in fact, that nurse was also in our buprenorphine program. And so he called the patient, he called us and talked to us, and we randomly asked this patient to come in and get a urine drug screen. And in fact,
she also had a care plan. So you can't,
Yeah, she had a care plan. And so we asked her to come in. And she was actually on a different medication than him. And sadly, she had both those medications, both his and hers, in her urine. And so it became very obvious that this patient and nurse was actually taking his medications on top of her own and replacing them. When the police went out, they found that she was replacing them with Tylenol. And so the story has a very good ending, because this patient was brought in and we had conversations with her. She went to treatment. She got her license back. Her nursing license is back working. But it was really a case where many of our physicians did not feel that it was important to check urine drug screens on older people who they were not concerned about misuse. And so we just this was one that we pointed out to our physicians, that this is why we check urine drug screens, is because many, many fun things can happen. And there are people with opioid use disorders who are connected to these patients that can then get help. So it all turned out very well, and she's back working. So yeah, just a nice way to show us that the urines can be helpful in many ways.
Yeah, it's trying to really remember the vulnerable people, whether it's a vulnerable adult or a child. You know, we've had patients where the parent is taking the child's Adderall, or you know, you can't get a screen on the child. You can on the parent if they're also with a care plan. So it gets much more complicated. And so sometimes, you know, that's a hard situation. You know, the parent might be struggling with some type of a methamphetamine use disorder or something, and the child really does need some type of a stimulant. And so it's how do you manage all of that? And those are like the little nuances that randomly show up. But it's always important to not just think, what are they taking? It's, are they not getting what they should be getting?
Yeah. The only other comment I'd make before we're done is that never underestimate as well patients on opioids who have normal drug screens, their alcohol use. And so I think it's important that we also be screening patients on opioid use, or who have opioid use and not necessarily an opioid use disorder. We're always screening for other use disorders. Remember, the most predictive thing of developing a use disorder is having another one. And so we see a lot of patients who are drinking a reasonable amount of alcohol on top of their opioids. And we need to always be thinking about screening them for that as well. And there are different urine tests and blood tests that we can get that are very helpful at kind of sorting that out if there's concerns from family. And we will talk about those some at a different time. So, any other questions from anybody? Any thoughts or questions that anybody has today?
I do want to add one thing. I almost forgot. The buprenorphine. So we have sometimes had patients who are on buprenorphine and all of a sudden their opioid is positive. Like patients who had been like in recovery for a long time and now their opioid is positive. And, you know, they're shocked. We're shocked. You know, they've sworn up and down they didn't take anything. And, you know, these people, you know, these patients, once they've been in recovery a while, again, tell you a lot. So we've gotten a few confirmatories on the opioid positive. And there is this weird, every once in a while thing where if you, because buprenorphine, the Suboxone, the Suboxone, I should say, not the plain buprenorphine, the Suboxone, which is naloxone with the buprenorphine, it has to dissolve in your mouth. Well, if they swallow it too fast, so that the naloxone actually doesn't get broken down like it should, the naloxone can cause a positive opioid. So when you get an opioid confirmatory, the only positive opioid will be naloxone. And so this is another one of those situations where you don't want to be like, oh, you relapsed or you lapsed when they swallowed their, you know, tablet too fast or whatever. So
yeah, and I think too the poppy seed defense is something that we're going to be talking about in about 6 weeks. I'm working on a talk now about what to do with patients who say, my test is positive because I ate a bagel with poppy seeds on it. And we'll talk a little bit about how that can affect our urine drug screen, but that's going to be on a regular echo on Wednesdays, probably 6 weeks from now. So, but that's, if you have questions with that, or if that happens to you, or you have a patient that comes with that situation, please don't feel badly about reaching out to us. We'll help you navigate that. All right, urine drug screens, tons of fun.
And ironically, I was at the grocery store the other day, and in one of their like specialty aisles or whatever, where they're like the holiday stuff, they have like a canned goods of straight poppy seeds, you know, to make desserts and such. I was like,
and tea.
We should buy this and see how much of this jar I need to eat. No, it was just crazy because it's quite a lot of poppy seeds in that container.
Yeah, and you can buy a pound on the internet pretty easily. So, but yeah, don't ruin my talk. So, all right. Well, thank you again, everybody, for coming. And what is in 2 weeks, Heather? Did we already put that on there?
Susan.
Oh, Susan.
Trauma.
Yeah. So that's always a great talk with Susan. So even if you've seen it, you'd want to see it again. So thanks everybody for coming, and have a good day and a good week.